All right, now we're going to talk about the CFTR modulators. These are the new exciting miracle drugs that have changed CF immensely. So we've talked about control of malabsorption, control of infection, control of airway inflammation. Now we'll talk about those CFTR modulators. So finally, we have something that actually is looking at the problem and trying to improve that ion transport problem. So it's a multi-pronged approach. The first one that was available was this potentiator, which is a drug that actually kind of tries to hold that chloride channel open on the cell surface and allow the chloride to move in and out of the cell. So it's trying to open that chloride channel that isn't working. The correctors actually fix and restore the function of defective CFTR protein. The potentiator that we had, well, I'll talk about that in a minute. There's also amplifiers, which are in the works that are not in any of the current compounds being used. But this third way was to make more CFTR. So we have correctors, potentiators, and amplifiers that all are trying to improve the CFTR enough that patients can have a good quality of life. So correctors, they were not the first ones to come out, but they are very important and correct the folding. As you remember that that ribbon-like structure that I showed you earlier that looks like a bow for your Christmas gift has a lot of, to get it in the correct shape, it has to fold correctly. And as you remember, a type 2 and specifically the delta F508 mutation is incorrectly folded. So because of that incorrection in folding, it can't work properly. So there's 3 drugs that have been developed that are all correctors, and some of them are specific for the delta F508. Lumacaftor, tezacaftor, and elexacaftor. So these 2 are the, well, anyway, so these drugs have all been used in different compounds and combined with our potentiator, which, like I said, holds the gate open, ivacaftor. So these correctors will improve the folding and therefore allow the CFTR to actually move to the surface. Otherwise, it stays stuck in here because it's misfolded and isn't able to make it to the surface. So there's no way that can work, right? This is the class 2 type of mutation, which is what the delta F508 is, which is, like I said, 80 to 90% of patients have at least one copy of delta F508. And a lot of these drugs are geared toward that particular mutation since it will cover most patients. So the corrector then will go to the surface and allow there to be movement through here, and then the potentiator will hold that gate open. So it's sort of like, I think of it as 2 arms holding it open. So we've got the correctors and the potentiators that work together. And then, wait, I don't have the amplifiers on here. Where did that go? I just went, okay, there's the amplifiers. All right, sorry about that. Ivacaftor is the drug that holds the gate open as a potentiator. This was the first modulator available. What I want you to know is that it's a 3A4 substrate. And so there's a lot of drug interactions. It's also a P-glycoprotein substrate. And it's also an inhibitor of CYP2C9. So you've got all kinds of problems here with drug interactions. Therefore, a pharmacist needs to know about this. So strong CP3A inducers should be avoided. right? Because if it's an inducer, it's going to decrease the drug concentration, right? And we don't want that. And also, it will decrease the CSS and decrease the wait, is that right? No, the half-life is going to get shorter, right? So we don't want that to happen. No, longer. I'm sorry. This will increase. It's just going to be less effective, right? So the half-life will get longer. Inducers. No, increased clearance. I'm sorry. Let me actually think about what I'm doing. So an increase in clearance will decrease CSS, and make it less available. And therefore, we need to give more drug, which is a very expensive drug, $300,000 per year. So we're probably not going to give more drug. We want to avoid these 3A inducers. And it also will shorten half-life, right? And we don't want that because that would mean we'd have to give it more often. We are not going to give this drug more often or more of it unless we absolutely need to. And therefore, anything that's an inducer should be avoided. Also, the other thing is these drugs need to be taken with a fatty meal. Fat increases the area under the curve 2 to 4 times. So must eat with fat. And again, this costs $300,000 plus per year for these drugs. So they're very, 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 very expensive. At the time these drugs came out, they were the most expensive drug. Now this drug, ivacaftor or Kalydeco, when it came out, it only helped like 5 to 10% of the population because it was very few types of mutations that it helped. But then they added correctors to that and got a lot more benefit. The final class, which we don't have any yet, are the amplifiers, which make more CFTR. So this is actually going to improve the amount of CFTR. So we can look forward to those being added as well. So this new drug that's been so magical is called Trikafta. Tri means there's 3 drugs. Okay, there's 3 drugs. There's alaxacaftor and tizacaftor, and these are both correctors. And then ivacaftor, again, is that potentiator that we talked about that keeps that channel open. I'm not sure I spelled that right. And originally we just had ivacaftor, and then we added ivacaftor to a corrector, one that's not here. And that improved things. But now that we have 2 correctors and the potentiator, this has made a huge difference in the chloride being able to move out and through the channel. So like I said, it's called Trikafta, it's tizacaftor and alaxacaftor, which are the 2 correctors, and then ivacaftor, which is the potentiator. And you can see, I don't know what that means. Anyway, this is approved. Actually, I think this is down to like 4 years. I don't remember now. I should probably look that up and let you know. But you just have to have 1 delta F508 mutation. You get 2 tablets in the morning and 1 that's ivacaftor only in the PM. Again, must take with fat, and avoid 3A4 inducers. This is a pharmacist role again. You can see an increase in liver function tests, and again, it's about $300,000 a year. It was approved in October of 2019. My son started it in November 19th of 2019, and he just finished running a marathon. He's just doing great. It's like a miracle. It is a miracle. It's a yay science thing. All right, they're all 3A4 substrates, so we have to be very careful about strong inducers of the 3A4 system. Also avoid inhibitors. These are your inhibitors, which are the antifungal drugs. You have to be careful. Grapefruit juice. It's also ivacaftor is also a P-glycoprotein substrate, so you need to be careful about some of these drugs being given. It may increase statins, glyburide, ticagrelor and repaglinide. At least the elexacaftor portion may inhibit the uptake of oat PBB1 and oat PBB3. But this is just in vitro, so this isn't as important as this and taking it with food. And it's got to be fatty. That's it. Future therapies. I have to tell you one thing before we go on, and that is my Isaac's doctor at down at Nationwide Children's in Columbus has had to take on another specialty because she said, I just don't have as many admissions anymore for CF. Isn't that a miracle? EA science. All right. Thank you.